I want to thank SAGES for giving me the opportunity to present our project. I'm Jessica Ardila. I'm one of the senior residents of the Cleveland Clinic. So I'm going to talk about bariatric surgery in patients with interstitial lung disease, and I have no disclosures, which is not that bright. So obesity has an effect on respiratory physiology that it's complex and poorly understood. Some of the changes that we see in obese patients include low lung compliance due to the excess of truncal fat, reduction of the expiratory reserve volume, and functional residual capacity, for which the patients usually have increased work of breathing shallower and faster, which concludes for them to have a restrictive pattern. So for this, some of the pulmonary complications after bariatric procedures have been shown to be between 1% and 8%. Interstitial lung disease is a rare disease that affects about less than 200,000 patients in the US per year, and it's a broad term used to describe a complex set of pulmonary disorders that is characterized by inflammation and or scarring of the interstitium of the lung parenchyma, and leads to dyspnea, hypoxemia, and a restrictive ventilatory defect on the pulmonary function. It is associated with increased perioperative morbidity and mortality, and several studies have been done within this patient population. Specifically, after lung resection in patients with lung cancer, the risk of pulmonary complications is about 26%, and some studies suggest that after non-lung operations, the pulmonary complication rate is about 11%. The most common pulmonary complications are pneumonia or acute exacerbations of the interstitial lung disease. There's limited literature on the outcomes of bariatric surgery in this patient population. So the aim of our study was to assess the safety and feasibility of bariatric surgery in patients with interstitial lung disease. Our primary endpoint was to assess the perioperative pulmonary complications and admission to the intensive care unit within the first 30 postoperative days. And our secondary endpoints was to assess all causes of perioperative morbidity and mortality in this patient population, and weight and pulmonary function outcomes at 1 year follow-up. This was after IRB approval. We did a retrospective review of patients with a preoperative diagnosis of interstitial lung disease who underwent bariatric surgery at our institution. The study dates were between 2004 and 2014, and the diagnosis of interstitial lung disease was confirmed by our pulmonologists. So we found that out of our 1,500 patients that underwent bariatric surgery, 25 of them had a preoperative diagnosis of interstitial lung disease, which was about 0.5%. 7 of these patients needed bariatric surgery to qualify for lung transplantation. So we found that their median age was 53. Most of them, 84%, were females, and their BMI preoperatively was 39. The most common specific interstitial lung disease diagnosis for our patients' population was connected to tissue disease related to interstitial lung disease, which was a little different from what the most common cause of interstitial lung disease is rated in the literature, which is idiopathic pulmonary fibrosis, which in our patients was only 20% of our patients. And here I listed the other specific diagnoses of some of our patients. And then, as I said, the pulmonologist confirmed the diagnosis of the interstitial lung disease, but also we did review the CT scans and found the characteristics of the interstitial lung disease pattern. Some of the comorbidities that our patients had that we also checked were very common to what all the obese population patients have, like diabetes, dyslipidemia, and hypertension. Of note, about 64% of our patients did have gastroesophageal reflux disease, which will be important later because that affected the decision on what type of operation they were getting. And here we can see the preoperative pulmonary function test. And as we can see, all of our patients, they had decreased pulmonary function tests compared to normal population, significantly for the forced vital capacity, the total lung capacity, the residual lung capacity, DLCO, and then the distance travel in the 6-meter walk that most of these patient tests take to assess their pulmonary function. Most of our patients, as we could have predicted, were ASA class 3, most of them, but range between class 2 and 4. Most of them underwent, between the operations they underwent, most of them had a gastric bypass, 68%, which again, it had to be with the fact that most of them also had a preoperative diagnosis of GERD, and because of their lung function, we wanted to decrease the incidence of reflux. 28% underwent sleeve gastrectomy, and only one patient had a gastric band. Most of the operations were done laparoscopically, one robotic, and one was converted to open but started laparoscopically. Out of our postoperative results, none of them required ICU admission, and none of them had pulmonary complications within the first 30 days. Only 4 patients had other complications, which was 1 patient had an anastomotic leak, 1 had a marginal ulcer, and 2 patients had an anastomotic strictures. So, which was our aim point of our study. We showed that none of these patients had pulmonary complications or unplanned ICU admissions. In our 1-year follow-up, we could see that the BMI decreased from 39 preoperatively to 30 postoperatively. Unfortunately, we did not have all the PFT values for the entire cohort postoperatively, but for the patients that we did have the data, we can see here how all of their function tests actually increased. So specifically, the forced vital capacity went from 62, which was less of the predictive value for the normal population, to 74, which was within the norm, and the total lung capacity, the DLCO and the distance travel within 6 minutes. So there was improvement, as I said, in the PFTs and the 6-minute walk 1 year after bariatric surgery, and a significantly improvement in the FVC and the DLCO. So of note, though, that we do need to make clear that some of this these changes can be also attributed to the fact that the patients lost weight, and this decrease in BMI could be also the reason why the main reason why they improved their pulmonary compliance and breathing efforts. 6 of the transplant candidates were now eligible for lung transplant, and 1 of them underwent successful lung transplantation. So we can say that bariatric surgery can be considered as a bridging treatment for end-stage lung disease with obesity to improve their eligibility for lung transplantation. Some of the limitations of our study, as any study that's retrospective and it was done in a single center, unfortunately it's a small sample size, but as I said, this is a very rare disease, so unfortunately we didn't have more patients with it. And then we did have, as I mentioned, some missing data on the PFTs and the 6-minute walk, which would have been ideal to see, to have more data on that. But some of this was due to the fact that some of these patients, especially the ones that were being worked up for a lung transplant, didn't follow up with the pulmonologist in our institution, but went to some community pulmonologists, so we didn't have that data to follow up on. So in conclusion, bariatric surgery would be relatively safe and feasible in patients with interstitial lung disease with acceptable perioperative morbidity, significant weight loss, and improved candidacy for lung transplantation, but the multidisciplinary team approach is important and essential for the good outcome in these high-risk patients. Thank you very much.